Welcome everyone to, I guess we have made it through a full NFL football season of Native Strong Town Halls. We are here in week 17. Back again. Thank you for allowing me the week off last week. It was nice to just get a little breather. But back again for our week 17 here with Dr. Lyle Ignace on the COVID-19 response. Not only, in the state of Wisconsin, Milwaukee, but we do kind of hit the Bemidji area, which is Minnesota, Wisconsin, Michigan, Illinois, and also the nation as well, how it's impacting us, how it's impacting schools, and many more topics. As for those of you who have been here before, we welcome questions. We encourage questions as we move along. There's a chat box, chat bubble window as part of the Zoom app. If you are joining us that way, that's just at the bottom or top of your screen, just looks like a little talk bubble. Click on that and you can enter questions that way. If you are joining us via Facebook Live, please just drop a comment in and we will moderate those as well and answer as many as we can throughout or at the end of the session. As always, we have our wonderful moderator with us today, Mark Denning. And with that, I will pass it over to Mark, and thank you again for joining us.
I want to say, Winnabuju and Maganaduk, Nadwe Benezi, Indigenous cause, Name Dodem, Anishinaabe and Dao, Neopid and Donjaba. Welcome, relatives. We are indeed in week 17, and it's a very important session because a lot of our young people are going to school. And if we got skilled school children in our home, when they go to school, everyone in the home goes to school. And we have to have the best available information that we can to make sure that our families are safe. If you have a question, that chat bubble is really important. It may be occurring to you right in the moment you're thinking of it. Take advantage of that, writing out that question and putting it up there. If that question gets addressed as we go along, we'll just continue to move along. As I try to say every time, please remember our relatives that don't have the ability or the privilege. What this is I have a privilege of having an internet signal. I have a great gift of having the availability of a computer. And I must say a lot of my family does not. And when I'm visiting with them, when I'm talking to them, they ask me a lot of questions, and I've learned a lot through these programs, and I'm happy to pass that information along. So we know that when you come on, you're representing a lot of different voices and faces out there. In our Native community, it's not just about the I, it's about the we. So you may not even have a question for yourself. It may be that you have a question for someone else. Please ask it and don't be shy. We appreciate that kind of participation. With our format, for those of you that may be new to the program and for those of you that have been through all 17 weeks, we usually begin with a look from our country, kind of a upward view, if we were up in the air and looking down on our United States and what's happening with COVID-19. Then we'll go through different communities, different areas, and especially Native areas. Precisely because a lot of us travel. We travel through the weekends, we travel through our ceremonies. Ricing is going to begin. A lot of you out there are going to be headed out within just a few weeks. And with ricing comes a lot of community work, a lot of contact with a lot of different people. So when you're traveling to those rice beds, when you're traveling to ceremonies, when you're traveling to relatives, it's good to know what's happening out there. And we try to stick to the Midwest. We don't cover the entire country, but that's why we do what we do. So you know, and you can tell relatives what's going on out there in Indian country. This is a native to native conversation. So with that, I'm gonna pass this over to Dr. Lyle Ignace of the Gerald L. Ignace Indian Health Center. And welcome everybody, and let's have a good program. Dr. Ignace.
Thank you, Mark and Jeremiah. Good to see you back from your short vacation. And thank you for returning back again. We're in week 17, and I have a lot of information to give you, so I'll just hop right into this. Worldwide, we have 23,903,000 cases worldwide. 7.6% increase from the week prior. This is trending downwards, and it has been a trend downwards over the last 6 weeks. So that is positive news worldwide. From a recovered standpoint, nearly 15.6 million have recovered, 10.1%. It's pretty steady. The number of fatalities, 819,000, 4.7% increase from the week prior. And you can see as a trend that has also been consistently going down, especially over the last 6 weeks. Here in the United States, 5.8 million cases, 5% increase from the week prior. And you can just look at, so these are percent changes that I give on a weekly basis. So you can see the trend here in the United States, just like it has been worldwide. The trend has been going down as well. In terms of recovered, almost 3 million have recovered, 5.6% increase from the week prior. That's been pretty stable. 180,000 fatalities, 3.7% increase. And you can see that as a trend has been going down as well. So overall here in the United States, this is also a positive trend that is going on. Here in Wisconsin, 72,260, 7% increase from the week prior. And again, you can see the same pattern that is going on here in Wisconsin. The trend has been going downwards as well. In terms of recovered, 63,730, 11% increase from the week prior. And that has been pretty steady and consistent. 1,100 fatalities, 4.5%, and that has remained relatively stable as well. Just a quick reminder, 573 federally recognized tribes in the United States. They're dispersed everywhere, and within the Indian Health System, the Indian Health Service, each block of area is designated as an area or a region, and there are 5.2 million self-identified natives in the United States. Half of the native population utilize the Indian Health System. That includes federal sites, tribal sites, and urban sites throughout the country. Nearly 70% of native population reside off the reservation. So it's important to recognize that individuals that utilize the ITU system, you can certainly bet that there are other natives who reside off the reservation that use the private sector as well. So important to keep that in mind. Let's get into the overall statistics. This is a data set from the Indian Health Service from August 25th. As you can see, the Indian Health Service regions are broken out here on the far left. As of August 26th, you have the number of tested, and in that second column, you have the overall number of cases total for that region. For the week of August 26th, so I highlighted the area that has at least a significant change. And this week, we see Alaska has 163 new cases from the week prior. That is significantly up. Bemidji also, that is us here in Wisconsin, Minnesota, and Michigan at 93. Billings, 147, that's been relatively flat. And then you have the Great Plains area with 200 new cases. Of note here, the Navajo Nation, you see 92. And that is a huge, huge accomplishment for the Navajo Nation to be able to have numbers of 92 is remarkable, and certainly a huge accomplishment to get down that low. Oklahoma City, 671 cases. That has consistently been elevated. In the Portland area, 166 new cases, and that obviously is a trend in the wrong direction. So at the very bottom, you see the total number of cases, 1,831 cases. That is 4 less cases than the week prior. But when you start looking at trends over time, you see that nearly half have a reduction in cases from the time period of July 22nd and July 15th. So to go from nearly 3,100 cases down to 1,800 cases, overall, that is a huge accomplishment. As we go from left to right, we see the percent changes. The average percent change is nearly 5%. And you can see that there are some areas that have changes, and this is based on the number of positive new cases. So the percent positive overall, 4.45 overall. Some areas are above that, some are below that. Great Plains, I think with their increase in numbers of recent, you can see that their percent positive, number of positive cases to the number of tests being done, there's a higher rate of identifying cases. Same with Oklahoma City, Phoenix, Portland, as well as Tucson. But when we start looking at how things have been trending out over time, you can see that Alaska is trending upwards. Everyone else, for the most part, has remained relatively flat or decreasing. Great Plains would be an upward trend, as well as Portland as being an upward trend. So overall, when we look at the entire system and the total number of cases overall in Indian country, the number of 1,831 has remained relatively flat. It's not a bad thing. It's just, it is consistently for the last 2 weeks. So that is actually good news. And we hope to see that continue as the weeks follow here. Looking at the areas a little more specifically in the states that make up the IHS region, we look specifically at Bemidji. You can see that first number, 1,070. That's the number of cases that that have been identified by the federal tribal urban programs in the Bemidji area, and that would include the states of Wisconsin, Minnesota, Michigan, Illinois. So if we just look at the ITU system in the Bemidji area of 1,070, there has been a 9.5% increase from the week prior. You can see that the changes, again, we're seeing this up and down trend here in Bemidji. When we look at Wisconsin and these states a little more specific, the numbers are different. That tells me that there are Native individuals that are utilizing the health system outside in the private sector, outside of the Indian Health Service. So we get different numbers. And so overall, in these states, we see a total number of 2,041. That's a pretty stark difference, almost 1,000 individual difference outside of the IHS system. So with that, 89 new cases from the week prior, 4.6% increase from the week prior, or I should say 4.6% change from the week prior, and that has actually been trending downwards as well. So despite increased cases in the IHS system, overall, and when you look at all of the states combined, the trend has been decreasing. Looking at the Great Plains, 2,233 cases, 9.8% increase from the week prior. Again, you see this last week it was down, this week it is up, and that seems to be how the Great Plains areas have been trending here. Overall, North Dakota doesn't report out on demographics, so I have nothing to report on there. But you can see the other states that make up the Great Plains. Overall, 2,573. I suspect if we added North Dakota, we'd probably be adding close to another 1,000 on there. So again, a big difference. It's just that North Dakota doesn't report this out. Overall, that was for the Great Plains, 149 new cases, 6.1% increase. And when you look at the numbers, again, we see kind of this slight bump up, a trend that's up in the Great Plains overall when you look at the states, the entire states combined. In Billings, 1,000, almost 1,400 new cases. That's 11.7% increase. That's relatively flat. It's about 1% less than it was the week before. So, but no real significant change. When we look at the overall of Montana and Wyoming and the number of cases that are being reported out by the states, there is a difference, 1,506. It's 162 cases as a difference, 12%. But overall, we see that the numbers in the Billings area actually decreasing. So kind of a mixed bag again. We see changes going on within the Indian health system and also combined outside. So it really does matter. If you want to look at what's going on in Indian country, you have to look at both systems and determine some inferences from that. Looking at the region as a whole, I know this gets a little complex, but I want to make sure that people can see the numbers and the trends that have been going on. Here in Wisconsin, 72,260, 7% increase from the week prior. But again, you can see the trend of new cases are on the downslide. In terms of cases, that should say 4,767, 681 cases per day. So if you look at the trend from the times I've been presenting, you can see that this has been decreasing overall. In Michigan, 4,922 cases, 703 cases per day. They've been relatively stable, flat, no real significant change. In Indiana, 7,000 cases. They were actually showing 1,000 cases per day. Indiana is showing an upward trend of new cases. In Illinois, almost 14,000 cases from the week prior, almost 2,000 cases per day. But again, when you start looking at trends, they are going up. In Minnesota, 4,600 cases, 659 per day average, and they have been relatively flat. They haven't had a huge change. So they're again a mixed bag of activity that's going on in the region. Indiana, Illinois going up, Michigan, Minnesota flat, Wisconsin is going down. Looking at the state of Michigan and the respective tribes, we can get a sense of the activity that's going on. So for the 11 tribes in the respective counties, we can at least utilize the counties as a proxy, although not absolute, of the activity that's going on with each respective tribe. So as you go down, you can see that there is a fair amount of activity that is decreasing or flat. And then as we get down more into the central part of the state, we see that there are upward trends that are going on. So like the Little River, Ottawa, 7 new cases. Typically they are really low in numbers on a weekly basis, but for this past week, the numbers are up. Gun Lake is up, Saginaw is up. And so again, overall, not bad, just some areas that have increases, but if we look at the overall number, of cases, of native cases in Michigan, 439. That's 24, just 24 cases from the week prior, 5.8%. And for the state of Michigan and the native population there, that is actually decreasing. So that is good news for the state of Michigan. In Minnesota, so again, we have the 11 tribes with their respective counties that they reside in. As we go down and look at the numbers, Leech Lake is probably the most significant, with the most significant number of cases in their area. Everyone, for the most part, is either decreasing or maintaining a relatively flat number of new cases. When we get down into the southern southwest portion of the state, we have the lower and upper Sioux and their counties. Not a lot of numbers, but at least for that region, the trend has been on an upswing. So looking overall, 582 cases of the native identified natives in Minnesota, 21 cases, 3.7% increase. And in the state of Minnesota, that trend is definitely decreasing. It has been for the last 6 weeks. So really, I think overall good news for the state of Minnesota. Looking here at Wisconsin and the 11 tribes, we can see that there's been some positive news that is going on. I think the most significant is the county of Outagamie and Brown County and Navajo Nation. Their region has seen 678 new cases from the week prior. Everyone else has either shown a decrease or a flattening of new cases. So the only real active, really heavy active area has been around the Oneida Nation area. 714 new cases, 714 cases overall, 51 new cases from the week prior, 7.7% increase from the week prior, and that has been relatively flat, no real significant change. So it's important when we look at these numbers, we kind of can make an inference as to where the high activity area is. And Outagamie and Brown County are certainly those areas that with a lot of activity going on. Looking at Illinois, 306 cases, 18 new cases from the week prior. I include Illinois because there is a urban Indian health center there, and it's important to acknowledge and account for their numbers as well. So coming back here to Wisconsin, this is as of yesterday, 714 cases, 51 new ones from the week prior, 7.7%. What's important here is that there has been no new reported fatalities. For a long period, almost 8 weeks, there was no new fatalities. And then last week I reported out within the last 10 days from last week, there's been 2 new cases, but there hasn't been any new ones as of for the past week. So that's good, and hopefully that maintains its number there. Looking at the demographics here in the state of Wisconsin by age group, I'm including numbers of this younger 0 to 9 group, mainly because of the going back to school and how that's going to impact our younger kids. So as you looked at this, you can see the overall numbers and the rates that are going on. And then to the far right, you can see August 26th. That is a date and time that I've looked at over the past week and the number of new cases by age group. And so as you go down, you can see there was 1,051 new cases. That correlates with the age group of the 20-year-olds. And so you can just get a better sense of which age group has the highest numbers, which are affected the least. It's the very young, 0 to 9, that are affected the least, followed by the very old, and then we have everyone else in the middle. But that age group 20, the 20-year-olds are certainly have the highest cases, and I suspect that will continue to be moving forward. So this is really looking at what's going on in different states and that age group distribution. You can see that nearly all of the states have the same curve. That younger population, that 20-year-old population, has the most significant numbers, as you can see here, as well as in South Dakota and Montana. It's not only a trend, but I think it will be what we'll see for a very, very long time. Looking here at Wisconsin at the 7-day average of cases, you can see we had that initial peak in late May, followed by a downsloping in June, and then July, after the July 4th weekend, it really started taking off, peaking at July 25th. And since then, despite having numbers in the 1,000, we are on a trajectory going down. We are trending down, and as of right now, 681 cases on a 7-day average is where we're at right now. And just looking at the daily counts, I suspect that'll be a trend that we will continue to see moving forward. So this is good news for the state of Wisconsin overall. The trend is going down, and it's consistently going down for a good month now. So that is good news. This is looking at Milwaukee. 23,461 cases, 405 fatalities. If you look at the center graph, you can see the activity by zoning districts that are going on. And so you can see that there's a pretty good distribution both on the north and south side. There are a few spots, and I'll highlight this later, but there's just a few spots that have kind of a larger circle. But I think, these circles here, just south of the highway, it's not a lot of cases. When you go into these areas, it's like 10 cases, 11 cases, but it's not a huge amount of numbers in these areas. So what I've noticed is kind of a less denseness to the number of cases, and I think that would be consistent with what's going on in Milwaukee, is the number of cases are decreasing. So, and here, if you look at the left lower hand corner, new positive cases per day, you can just see the trend is just steadily and consistently has been going down and down and down. Remarkably, the number of fatalities that are occurring in Milwaukee has actually gone down significantly as well. There may be reports of maybe 1 or 2 cases maybe a day, but then you also have days that there are no new fatalities, and that's actually a good thing. It's good to see that there are 0 days. And I think over the last month we're seeing more 0 days than there were in the very beginning. So so hopefully that is a trend that continues to keep going. This is looking more specifically at that new case per day. We had May 18th, July 8th. These are kind of those high water marks that have been going on. But more recently, at least in Milwaukee County, that number is decreasing. And as of the 24th, there was only 59 cases. So again, not all, when you say, well, 59, it's not a lot. It's still present without a doubt, but it's not as significant as it was even 2 months ago or 4 months ago. the new numbers of new cases are continuing to go down. So that is something that is what we want to see. Something new that I've been looking at, and I know a lot of organizations, hospitals, public health departments, schools, they're utilizing this percent positive rate as a benchmark of whether things are good, whether things are bad. And I know this number 5% positive rate is kind of stuck. I'm not sure why 5%. Maybe if someone knows why 5% is actually used as a benchmark, whether or not things are good or bad. Anyways, I looked at the city of Milwaukee and the county, Milwaukee County as a whole. So if we look at the left side, Milwaukee County, the 7-day average as of August 24th was 4%. I'm sorry, was actually 5%. It's not bad, given where we were even 3 months ago, where we were in double digits of 10%. I suspect this will be a continued trend because the numbers we're actually seeing as of the last couple of days, the rate, now this is a 7-day average. So this week has actually shown fewer positive cases, and that percent positive is going down. So I suspect in next week that this 7-day average will actually be less than 5, like more in the 4s. And if we get down into Milwaukee City proper, we see as of August 24th, the percent positive was actually 2.95%. So again, you can see the trend, you can see the percent positive. Again, several months ago, double digits, even as high as 25% back in April. But now we're talking about a percent positive of 2.95%. So obviously very good news overall, and that's what we want to see. And so if organizations are using this 5% as kind of this benchmark for activity, this is a positive trend that's going on, not just in the city of Milwaukee, but I think overall Milwaukee County as a whole. So that is good news. That's what we want to see. Looking at the city of Milwaukee a little more closely, again, we're looking at this 7-day moving average. And as of, what is today? The 27th, this was August 26th. The 7-day average is 39 cases. 39 cases in the city of Milwaukee, 39. When you put this in perspective, given the overall population of Milwaukee, 39 cases a day is not a lot. It is not a lot of cases. It really isn't. Now, on the right-hand side, we have the number of cases by zip code. So looking at Milwaukee, you can see that there is a yellow highlighted zip code and a red zip code. For the city of Milwaukee, the areas with the highest number of cases is in zip code 53204 and 53215. Again, this is important because we want to know what the distribution of cases are in the city. It's actually not on the north side, it's actually on the south side. And it's in these 2 zip codes. And it's important because the agency, the Gerald L. Ignace Indian Health Center, resides on the south side and exactly smack dab in the middle of zip code 53204. Now, I bring this up because when we look at demographics, native demographics of the city of Milwaukee, a good portion of the city's natives reside in these 2 counties. These 2 zip codes. So that's why I'm highlighting that, and that's why it's important to realize that as we know demographics of areas and not just states, but also reservations or counties, that when you look at the demographics very specifically, we get a better sense of the activity and how this can impact natives, specifically in this case of coronavirus. So just looking at the number of cases in Milwaukee. If you look to the far right, 94 cases. You know, I've been following this since we've been starting all of these town halls. So 94 cases, 2 new cases from the week prior. So not a dramatic change, but nonetheless new cases in Milwaukee. This is just a reminder. If we start looking at symptoms, and I know we all talk about fever, cough, shortness of breath, and those may be the more classic symptoms of having coronavirus. But as time has gone by, we are picking up more and more symptoms. We know headache, runny nose, muscle aches, fatigue, sore throat, all are kind of part of having a cold. So I know people will say, you know, I have a fever, I have a cough, but I'm not short of breath, so I don't have it. I just have a common cold. I hear this all the time. And it's like, well, you know, given any other time, you're probably right. You just have a cold. But given that we're dealing with coronavirus right now, that would certainly be enough for me as a provider clinically to suspect that you do have coronavirus, and I'm going to send you for testing and wait for the results. But again, there are other symptoms, loss of taste or smell, and we're dealing with GI symptoms. GI symptoms is not typically, you would think, gosh, you know, I may have an upset stomach, I'm not very hungry, maybe got some cramping, but diarrhea, you know, everyone gets diarrhea. But this, in combination with any of the other symptoms, could be a good indication that, yes, you do have the virus. I would send you for testing if you came to me with those types of symptoms. So I know right now that we are all in this mode of going back to school. I've talked about going back to school, the K through 12, but I want to kind of elevate it a little bit more because we also are dealing with going back to school for college. We have families may have kids that are going back to college, maybe they're first-time freshmen. So it's important. What I wanted to bring up was, you know, we've talked a lot about K through 12 age groups. Now I want to kind of hone in a little bit on this 20-year-old age group and what I'm hearing and what I'm seeing in headlines throughout the country. So we hear about colleges, we've heard about colleges going from in-person to scaling back to going online. We've heard schools like North Carolina, Notre Dame, Tennessee, Michigan State, University of Connecticut, South Carolina. So there are colleges all throughout the country that are initially went into this mode of in-person, but defaulted to being online. So I've been kind of scouring the headlines here to figure out, you know, what are people seeing and how is this being looked at. So I don't know if people remember this, but Emory University about 3 months ago was actually tasked to be kind of this research-based program to help kind of do all of these observational studies and research investigations to kind of lead the country in what's going on in terms of trending. And so what Emory came out with recently is that they were finding that college age attendees may be lending to that super spreader the term that we've heard of. Now, a couple weeks ago, I had mentioned that the CDC had came out with a paper I think at that time, everyone felt that the kids, K through 12, were the super spreaders. And CDC actually came out against that as that being not what is being observed here in the United States and even abroad in European countries, that kids K through 12 were not the super spreaders. But what we may be talking about, who are the super spreaders, are now this younger age group, these 20-year-olds, and we've heard in the news about places like Notre Dame. They had over 100 cases, an outbreak just like this, just like that, and within days they've gone from in-person down to online. Just like in North Carolina, there was an outbreak there, and again, so we're seeing these clusters of activities that are going on. And so Emory had came out and they said, well, looking at Georgia, Emory is in Georgia. So they looked at Georgia and kind of the cases that have been going on. They found that at around 2% of cases across 5 counties studied were responsible for 20% of infections. Well, that's a big deal. And that's a small portion of a group, an age group, responsible for 20% of infections. That's a big, big deal. And so that was one of the highlights I took from that paper, is showing that there is a small cluster of individuals that are lending itself as being the cause of a greater portion of infections. So kids K through 12 may not be the super spreaders, but these younger age 20-year-olds may be the ones that are the super spreaders. So that's important to keep in mind. Another thing that I found, again, large outbreaks that are occurring. If we look at Florida, the median age of virus had declined from an average age of 65 in March to 40 in mid-July. And again, we're talking about this younger age group. Just like in Wisconsin, we see that the 20-year-olds are the highest group. They've seen that as well in Florida. So when this all was first occurring, we were seeing tremendous amount of numbers, and they were predominantly of the older generation. But since then, that bell-shaped curve has now switched from older age groups to now the much younger age group, and I see this as continuing to occur as time goes by. In California, people aged 18 to 34 went from 24% of states' coronaviruses in May to 35% in August. So again, and in the same respect, the 65 also decreased from 22 to 11% during the same time. So again, this is just highlighting that notion. What I've been speaking about is that trajectory of cases are predominantly now in that younger age group, 18 to 34. In California, again, they have tremendous school systems, big school systems, universities, colleges. Again, when we start talking about where are all these infections coming from, I think this is a pretty good indication that it's this younger age group that is the primary driver of new infections. In LA County, infection rates among ages 18 to 29 quadrupled from June to late July. Again, that same theme, LA County as being the largest county in the state of California, again, that huge younger population are being the main drivers of what we're seeing in terms of cases. A couple other things that have come out. One that I haven't put on this list, but I will mention that the FDA had issued an emergency use authorization, an EUA, for the use of convalescent plasma therapy for the treatment of COVID-19. Now, it did come out with some controversy because I think the convalescent plasma therapy was touted as being kind of not so much an absolute cure, but its use did result in a favorable response of recovery and survival. Now, its emergency use authorization was provided because, as of right now, the tools that providers have, hospitals have to treat COVID, there are not a lot, and so, you know, there are still you know, double-blind controlled trials that are ongoing for other medications. Remdesivir is that leading one that is actively being used. But the principle, the theory behind using convalescent plasma therapy is that if anyone has ever donated blood, you know, you can donate your red blood cells, and, you know, if you lay down, they put a needle in and the blood comes out. So you can do plasma. Plasma is different than blood. Plasma is all of the material other than your blood cells. And in that plasma, in that solution, that liquid, are is the antibodies. So if someone has had COVID-19, they've recovered and have demonstrated that they have a level of immunity, these individuals could donate their plasma, and it's collected, spun down, and provided to be used for the treatment. Now, what's going to come out in a more probably detailed manner of protocol and when to utilize the plasma is early on in someone's illness and hospitalization. So what I suspect will be found will be that the timing of treatment is going to be critical. Now, right now, I think they have been using plasma therapy throughout the country, but their use and the timing of use has been, there's a wide range. So is it when people just come in and they're kind of sick, they're sick enough to be in the hospital, but not in the ICU? Because those two different individuals and their symptoms has a huge difference in terms of prognosis and how people are going to recover. We see a lot of people that get admitted, observed, maybe stay 24, 36 hours, they recover and they go home. But we also see people that just continue to progress. They progress and they get sicker and sicker and sicker. And so the decision comes, when do you treat someone with this plasma therapy? Do you wait until they're in the ICU or when they get on the ventilator and then use it? Or do you use it when they first come in and it looks like they are progressing to get sicker? Is that when you do it, before they go to the ICU and get intubated? And the answer is probably yes. So the timing of when and the decision to use plasma therapy is going to be could provide a big difference in terms of prognosis and trajectory of people's recovery and survival. So I wanted to bring that out, and I know it comes with some controversy because, you know, people are saying, well, the numbers don't support what has been touted as being an effective treatment. I think the use authorization of this allows doctors and hospitals to make that decision when to use it and how to use it in terms of that timing of when to use it. So, so that emergency use for individuals is going to be a big deal, and that's what's going to come out. The other thing that's not on this list, and I know people are probably going to ask me this, is what the CDC did this week. The CDC came out with, and they changed their guidelines on testing. If you asked me last week, the CDC was pretty consistent in saying anyone and everyone who wanted to test should get tested. That was pretty much their thought and part of that guideline. However, this week that changed, where now they're saying, well, not everyone needs to be tested now. And certainly people that are asymptomatic, it's not necessary for people to get tested being asymptomatic. And it left everyone scratching their head because that's not what the CDC came out with several weeks ago, or even like a month ago, where it was like, you got to get tested, you got to get tested. If you're asymptomatic, if you feel like you got it or been exposed, yes. Now, the thing right now, what changed? And I think what's changed is the notion that just having an exposure or feeling asymptomatic or thinking you may have it, even though you don't have any symptoms, but I want to get tested. I think that high negative rate of testing, not that it's a bad thing, that's good that there are a lot of negatives, but I think there's a general sense that we are unnecessarily over testing individuals that were more than likely going to come back negative anyways, if that makes sense. Now, is it Dr. Redfield, I think is his name, from the CDC, basically had come out and said, kind of backtracked on testing. It's not to say that we're not going to test you, but he kind of came out with very kind of stricter notions of who should get tested. And so now we're saying, well, if you have symptoms and feel ill, yes, get tested. Now, what's different, what I'm going to say next, is a little different from what has generally been the trend of what we've been doing. So individuals with a significant exposure, and that is exposure to someone who's known to be corona positive, that you're not protected with a mask or take necessary precautions and not social distancing, or if you've been in the same room or vicinity of an individual less than, more than 15 minutes, that certainly puts you at a very high risk. And that's a significant exposure. We're not talking about the casual walk by or, a 5 seconds, in the general vicinity of someone who's known positive. We're talking clearly in a room, more than 15 minutes, unprotected. You're not taking the precautions to protect yourself, or that other person isn't taking the precaution of face masks to protect you from them. So that's what you would say is a significant high risk exposure. Certainly people that come from vulnerable populations, nursing homes, long-term care facilities, critical infrastructure workers. So this would be healthcare workers, essential first responders, hospital employees, essential workers, and that could be individuals who not necessarily work in a health field, but let's say grocery stores, where there's a lot of people, you're always exposed and interact with lots of people on a regular basis. So these would be the individuals that would lend yourself to a higher probability that if you're going to test them from an exposure, that they would actually have a positive result. So there's not to say that you can't get tested. You can, because the test will be there without issues. The test will be there, but they're trying to put a higher emphasis on that kind of upper tier, higher risk category, where if you do a test, the probability of that individual being positive, you can identify in a much quicker fashion, if that makes sense. So I know that's a long explanation, but I at least tried to tackle it because it's a confusing message that is the CD has come out. And I understand it, I get it, But it does lend itself to confusion when this whole time up until now, we've been telling everyone to get tested regardless of symptoms. Now we're kind of reverting back to high-risk exposures. Who would that be? And obviously a symptom-based approach to testing. So it's kind of like a two-tier. High risk, known exposure, yes, let's test them. People who are asymptomatic, who've had maybe the faintest of exposures, but and absolutely no symptoms, that becomes more of a clinical decision as to say, should this person get tested? An asymptomatic person, should they get tested or not? If your risk is absolutely low and no symptoms, I would lend itself to saying, I don't think you need to be tested, but you need to be cautious and protect yourself, distance and a face mask. So it still muddies the waters a little bit, but it gives, I understand that there's kind of a priority as to symptom-based exposure risk, but asymptomatic and limited risk, if none at all, there's a different mindset or priority to say who should get tested and who should not be referred for testing at that moment. I hope that makes sense. Oh, there's other point to that too. So let's say in that very random, exposure, let's say just in passing, or you heard, hey, my grocery store is over here and, I was there, but who knows, there was someone that came up positive, blah, blah, blah. I'm asymptomatic. So if I get, let's say the exposure was yesterday, and say, well, I don't feel anything, but I'll go get tested. I would tell you, don't get tested, because we know that just a simple exposure like that, it will take several days for you to actually demonstrate an infection of yourself or with symptoms. It would take several days. But if you got exposed and then we test you that day after exposure, it's going to come back negative. I guarantee it's going to come back negative. And so testing in that way doesn't lend you to catching more people. It just lends you to say, hey, we have another negative. And it gives you a false sense of security that you don't have it, even though you may have been exposed. It may be 3, 5, 7 days before anything would change or lend me to say, yes, you should get tested. Sometimes you may have to wait, but again, it really defaults back to protecting, safe, distance, cleaning, masks. I mean, all of these things that you need that we all been doing before I would say, yes, you should get tested. So I want to get to our special guest today because we want to talk about masks, but just a quick reminder, we have Safer at Home kits here at our facility. Please call Miss Terry, 316-5051. Set up a date and time. We'd be more than happy to give you a cleaning kit that includes hand sanitizer as well as masks and some products for home cleaning and disinfectant. We have programs here that help support people. We have virtual discussions regarding prevention of diabetes and high blood pressure, cholesterol. We have our Circles of Strength program to help support individuals that may be that have been victims of sexual and domestic assault. We also have our Youth Empowerment program to help support Native kids, especially during the school year. If you have any symptoms, as I mentioned, don't hesitate to call us, 414-383-9526, and we'll certainly go through an evaluation and assess the urgency of testing, and we'll set up a date and time for that to occur. Just a quick reminder, wash your hands, wear a mask, remember, avoid big crowds, social distancing, and it should be imprinted on everyone's brain with this public messaging. So, but it's a quick reminder to do all these things to help keep you safe. Now, I know we had a short demo last week about wearing a mask, how to put on a mask, but I'm going to turn this over to Mark, and he can explain and walk you through these pictures of kind of using a dual covering. But I'll leave that to Mark. So, Mark, help us walk us through a double covering mask.
So thank you, Dr. Ignace. I just wanted to bring to front of attention on everybody's minds. We do have 3 questions in a holding pattern, and we're going to get to those. So I want to do this as quickly but as responsibly as I can. With school starting, we had a lot of dads that sew. We got a lot of moms, aunts, and uncles that are kind of making those really nice things to send their young people back to school. And part of that isn't just getting the right book bag or the right kind of stuff to go into that bag, but they're also kind of, hey, what kind of mask? There's something to encourage that young person, and they make masks. So we did talk last week about what kind of masks work best. And over the weeks, we've talked that surgical mask is your choice to do what you needed to do when you're going out there in public. And we did talk about cloth masks. So just as you're looking at the screen, just a reminder for folks that are using this kind of mask and they put it around their face, that's not going to protect you from much at all. So that kind of is out. You want something better, and that is a surgical mask. They look like this. The blue or white, different colors. What we have here, what Dr. Ignace said was, well, if we can combine barriers, it's even better. So that's what we have here. We got a lot of people out there that are making masks, and they look like this. They look like they can even be plain. Or this kind of thing. Teachers, students, they're great. But this one that you're looking at the screen has a pocket inside of it. So not only does it have a single layer of material, but it has a double layer. So if you're looking at kind of picture number 1, that's the mask, the finished product, outside material, inside material. That's 1 and 2. So that's the final thing you get. But you also want to combine it with that surgical mask that can be replaced in and out, and the cloth can be washed. So if you move over to number 4 here, the idea is that you combine these masks, and the way to do that is what you're doing is you create, if you look very close at picture number 4, there's a slit or a opening that mask can be slid into, the surgical mask. So that kind of the 5 picture is where that's sliding into the mask quite nicely, because it's made for surgical masks. So of course, some are going to be smaller because they're for kids. Some are going to be larger for adults. Next one. So 2 pieces of material. On the back side of it, you have a place where you can insert the surgical mask. 6, you can see where the mask is going in. The 7th picture is where it's completely inside, the mask totally flat and against all the corners. And then the pictures 8 and 9 are it being closed, and then that's where we're at. So for folks that are making these kinds of masks for their young people, for themselves, for family members, for gifts, it's kind of from me saying, making these masks with these 2 different parts, if you want to have something that's representative or has symbols on them, use this kind of representation where in the back part of the cloth there's that opening, and then the mask can be slid in. So we did talk about this a few shows ago, but we didn't have visuals of it. So thank you, Jeremiah, for putting that one out there and making it a little simple. That leads to a question before we get into the next 3 questions. And Jeremiah, we're going to go to you with those questions in just a moment. Dr. Ignace, I was out and about, ran into a Native family. They said, hey, tell your cousin he's a funny guy. Meaning I started laughing because they know we're related.
Yeah.
So, and what they said, the last show they watched on delay was that you said if you got a blue mask, there's a lighter side on the other side.
Yeah.
So he gave me this. I got this from the Gerald L. Ignace Health Center on a giveaway, and there's no kind of looking at how do I put this on because both sides are white. Then he handed me another one that came from another Native organization in Milwaukee that was blue, but it's blue on both sides.
Oy. Okay.
So the question is, when we got little Johnny, and we talked about him last time, we want to put these masks on correctly. We got these masks like this. There's the pull. If you can see here, it goes, which way, this way, or do we turn it the other way around? So that's our mask question for Dr. Ignace today. This way, that way. Do we look at the sewing? What do we do? Obviously, you showed us last time, this strip is the nose piece that goes up on top, and that goes across the nose. So we know the top. So there's the question, and we'll hit our other questions. Which side of these do we wear when they're same color?
So you showed the kind of the light beige one, the other one. Yeah.
Okay.
So that one is kind of this universal. It doesn't matter which side. It could be that way or the other way. It really doesn't make a difference. So that's okay. The one you just showed, this one is kind of more of a fabric based. It's a decent mask. So you showed where the strings are attached on one side versus the other. So so that side, the side that has the strings would be the one that faces that'll be face your face, and that's how I would wear it. Yeah. So the side that has the strings, would be the side I'd have flush to your face, and then
Okay, Jeremiah, we have 3 questions in a holding pattern. If we could go to those questions, could you bring those forward, please? They're great questions because there's some deeper concerns out there in our community. And thank you for your patience with the masks, everyone. And when you make them, please kind of hit that 2 style where you can insert the surgical mask. Jeremiah?
Yeah, thank you, Mark. So we had a question pretty early on, kind of going through your numbers, and I know Mark, you had brought this up, early on in the stages or early sessions of, where do you or how do you trust what's the numbers that are coming out, and so one of our viewers just asked, where are we getting our numbers? I guess overall, and then I guess just because there are so many out there now that are coming out from whether it's the CDC, whether it's a state's Department of Health, whether it's the the White House, I can't remember exactly what it's called, but you know what I'm getting at. And then, like I said, so, how do you know which one is the right one? And I guess where are you getting your numbers from?
Yeah, so I use several different sources. So if I'm talking generally, I'll use Johns Hopkins as my data set, and I stay consistent. So if I'm going to use a resource, I've used Johns Hopkins consistently from the very first session to as of last night, week 17. I stick with the same resource. So I'm not deviating from source to source to source because the numbers are going to be different. So as long as I stay with that same Johns Hopkins resource, that'll be my consistent data set. That's giving kind of overall numbers. When I'm looking at another resource, when I give numbers, let's say Wisconsin, I'm consistent on using the Wisconsin Department of Health System as my data set and my source of information when I report out on specifically Wisconsin. I use the Milwaukee Health Department, the City of Milwaukee Health Department. So I stay consistent. I don't mix and match them. I stay consistent. So When it comes to native numbers, the native numbers that I specifically use, I use the Indian Health System, the IHS system as a data set, and I stay consistent. So when I talk about IHS system, I use that same data set from day 1 to week 17. When I look at overall numbers, I look specifically at every state. Every state has their health department website. So again, I use their numbers, and I'm consistent when I report out, and I'm consistent in that regard. So I have a lot of resources that I utilize, but I stay consistent from week to week, and I use the same data sets. That way I don't deviate, mix and match, and I stay consistent. So I hope that helps. It's important to be consistent and use the same data set as a reference or a context of information. As long as you don't deviate from that, you should, the numbers are consistent. Now, if I started mix and matching from Johns Hopkins to, another different information set and flip-flop back and forth, it's just, the numbers aren't going to make sense. And so I stay consistent in that regard.
Makes sense to me. Thank you, Dr. Mace. Another question we had, and this is kind of as we're kind of going into the fall season here, school's starting. Everybody else knows what that means as far as flu season coming along. And so the question was, do you anticipate an increase in cases because of the flu season as far as COVID versus flu? And then when do we expect to have the flu vaccine available at our clinic? And I know we have started kind of pushing it out as far as a message on social media, newsletters and such, that, give us a call and, schedule your vaccine. But yeah, if you could get into those questions as well.
Sure. So flu season is literally right around the corner. It typically starts Labor Day weekend and into September. The vaccine is being pushed out a little bit sooner this year than normal. So depending on which vendor you use to get the flu, or I should say hospital-based systems, clinics, Indian Health Service, any health system, it really depends on what vendor you use to get or obtain your vaccine. We use multiple different vendors, and so we are getting batches of vaccine at various times. Now, September 1 is the date that they'll start shipping out. So starting next week, there's going to be a heavy activity going on to start distributing vaccines. In particular, adult vaccines and kid and adolescent dosing. So vaccines should be in your clinic, I would think, by September 14th. It should be in the clinic that you utilize in your region or in your area or a city or town. Now, with that being said, it's kind of interesting, the dynamic of flu, because we know every year, the flu occurs. Now, what's different this year is that everyone is masked up, everyone wears gloves, they're disinfecting, they're washing their hands, they're using hand sanitizer, they're keeping their distance. So what's going to happen with the flu? Well, I suspect that what's going to impact this is probably twofold. One is the new normal that we're currently doing, and then the flu vaccine on top of that. What I suspect is, yes, we are going to see flu, but I suspect we will not see flu hit us until probably there's going to be a delay in flu hitting us, and it may not be of a higher load or caseload of flu than we've seen in previous years. Now, what I suspect is that the flu may not hit us until after Christmas. Now, No, this is completely an observatory um, recognition on my part, but I flu typically doesn't like hit us communities hard until after Thanksgiving. And the reason why I say that is up until that time, people are, going about their normal, going to work, going to school, doing their own thing. It's only when there are mass get-togethers, and Thanksgiving is that kind of first mass get-together that occurs that lends itself to spreading the flu or even the common cold. That's what typically would have occurred, I think, going into this season. However, now, because there's the flu vaccine, and I'm sure I recommend getting the flu, especially to individuals at high risk, absolutely should get the flu vaccine. And I think there's just going to be a higher demand for getting the flu vaccine. Second, because we're all masked up, because we're all washing our hands and using hand sanitizer, I think there's going to be less of a prevalence of flu, at least in the early part, and it may delay the flu until after Christmas. Maybe there'd be a very low prevalence of just flu in general, just because of all the things we're doing. Now, what will mitigate this even further would be flu vaccine, and if and when that flu vaccine, not flu, but the COVID-19 vaccine comes out, both of these together is going to be a huge game changer, I think, to how we view cold and flu season from here on out. Reason being is I think a good majority now are actually thinking about getting the vaccine, the COVID-19 vaccine, and even more are going to get the flu vaccine this year. So getting both of these are going to have a tremendous impact on what we typically call the flu, typical cold and flu season, and we may start seeing lower numbers when it comes to both COVID and flu this year.
So just a really quick add-on to that. So because you mentioned the delay and maybe the flu kind of showing up or rearing its head, would you suggest, is there a time frame you then would suggest getting the vaccine? Would you kind of delay to get the vaccine itself?
No.
And then also kind of in addition to that, you mentioned, COVID and the flu occurring at the same time. Do you see a possibility of, inflated COVID testing numbers, not necessarily positive numbers, but just people maybe getting tested because of some of the similarities in symptoms?
Yeah. So to answer the first part, so yes, I would definitely recommend, if you are considering getting the flu and you want the flu vaccine this year, I'd say the sooner you get it, the better off you're going to be. So yes, if you're thinking about it, you want to get it this year, if your health center that you go to offers it, set up an appointment and get it, not just for you, but your entire family. So yes, to getting the flu. I'm going to get it when it comes available to me. When it comes to flu and COVID, and so there's going to be a term that's going to be thrown out there. You may have seen it, you may have read about it. It's called ILI, or influenza-like illness. ILI, influenza-like illness. So if you go into any health department website of any state or any local area, you're going to see this term ILI. And so that's influenza-like symptoms. So that could be like cold symptoms, or it could be COVID. So what we're seeing in ERs is both ILI and COVID-19 symptoms. They're almost one and the same, and more than likely you're going to get tested. Well, not more than likely, you are going to get tested. Now, hospital-based do use the rapid analyzers to determine, like, preliminary upfront, yes, you have it, or no, you don't. So what I see in ER numbers is that there is a good portion of ILI cases coming in and COVID symptoms come in. So it's more than likely maybe a cold, maybe a bad cold, but yes, you have symptoms similar to COVID. It really will depend on if you are positive or negative, and that's how you get determined. But it's already occurring. It has been occurring. So and that's the hard thing about COVID is that it's so similar. It is so similar to either the mild version of COVID and having cold-like symptoms to COVID-19 bad symptoms that would resemble influenza or flu-like symptoms. And so that's anybody who comes in now with cold symptoms, mild cold symptoms to flu-like symptoms, you're going to get tested. And so it really makes it harder to differentiate who gets the test or not. You're going to get it. If you have any cold or flu-like symptoms, you're going to get the test. So now what I've noticed is that the trend, at least in some counties, the trend of ILI and COVID is going down right now. But that could change as we get more into the cold and flu season. That's going to change. Yeah.
All right. You got one more that's kind of, you mentioned college, kids going back to college and kind of that fiasco that is people going back and then getting virtual. What is one of the most important messages that we can give to American Indian students that are, having to attend college online probably for the first time this fall? And I know, this is probably hits home for a lot of us who have family members or who, are attending college for the first time or, now getting to experience it virtually for the first time. So I don't know, what would your message be to them?
Yeah, I mean, it's a different way of learning without a doubt. And it's, so there's kind of two parts to that. One is having a college experience and all of the college atmosphere and environment activities that come with that. And then there's the education part of college, certainly as a freshman. So two different experiences. The learning is different. The experiences are different. I think if there was one thing that you should not deviate from is following the rules. And what I mean by that is doing your part, at least be accountable to yourself. So the experience as well as the in-person activity of education, just you can have both. Without a doubt, you can have both. In these kind of guideline rules, recommendations that have been out, and they have been out for so long with using the mask, using the hand sanitizer, there's just going to be two things that you absolutely have to have in your backpack: masks and hand sanitizer. If there's two things that I'm going to recommend that you have on hand with you, especially on campus, yes, absolutely do those two things. It will reduce your risk tremendously. Now, that should apply to both in-person education. That means on campus, going to wherever that class may be. Just maintain those simple rules. As far as the college experience, I know it may not look cool, but if you still want to get a college experience and all the fun and activities, try to limit that exposure. Try to limit, you could still be in a gathering, but maybe it is now with a mask. I know it may not look cool and you may get funny looks, but it's going to help protect you and keep you safe. Those two things, sanitizer, mask, like a mask that Mark has on right now, or maybe even a mask, the dual, with the surgical mask insert, maybe you got to style it up a little bit. If it looks cool and it's a dual mask, like as Mark has put together here and showed you, I'd say do it. And those are the two best things I could suggest to help keep you and keep you safe.
So, Dr. Ignace, I do have a question, last one, and we're going to round out today's experience
Mm-hmm.
conversations. One is when little Johnny and little Jill go to school, this is what they're going to see. You know, this is coming at them,
Yeah.
and they may not be used to it. And I think in the future we should talk about what young people are going to be seeing and experiencing when they go to school.
Yeah.
Because they're not going to have facial cues. They're not going to that touch that they're so used to doing. But this
now includes a conversation from a teacher, and that's this kind of thing. Now this is a mask that
That a face shield.
seeing these face shields. So this comes from educators. They're going to be looking at anywhere between 16 and 28 little Johnnies and Jills, and they want to stay as healthy for as long as they can. I mean, and we're talking about different age ranges from kindergarten all the way through 12th grade college. Any insights into whether these add to the protection of the teacher, or why is it that someone would wear something like this, and is it worth it for them to invest in something like this as an extra layer, as someone's going to be interacting with these students for 4 to 5 hours a day?
So my thoughts about using the face shields only is I would not recommend it. The reason being is face shields are only for that gross exposure. So if little Johnny's running around and coughs in your face, you would actually want a face shield. That would be a direct protection between a sneeze or a cough on you. But again, that face shield is exactly what it is. You still have the sides and the underneath, so we know that particles are aerosolized and can, even though it may not get on you, it can go around the mask. So I would not recommend a face shield as protection. If you're going to use a face shield, and if you want to be more absolute, then you could wear the goggles. You can wear goggles, and when I was back in school, we had the safety goggles, and that would be eye protection. But I would also wear a mask like what Mark is wearing right now, in addition to that face shield. So if you want, the face shield itself is not a good way of protection. It is wearing a mask. Without a doubt, wearing the mask is the best approach. Now, yeah, just like what Mark's doing right now, he's got the face shield, he's got his personal glass eyewear, and a mask. That would be more absolute. That's pretty close to hazmat level, but it's pretty heavy duty. And you look like you're in some horror show right now. But if you're looking for a high level of protection, you would have to wear all three of those items. You're on mute.
We're coming to the end of our program, and I want to thank everybody for dialing in. As usually, we go to you for the last word. And again, I think next week we need to start talking about those students and those reactions when they go into those new environments, and we will. So Dr. Ignace, if you could give us your last words for today, and thank you to everyone for coming in, and please continue to ask those questions and get out to your relatives and speak for them if you can, by coming here and asking the questions they have. Dr. Ignace?
Yeah, thanks again, Mark. So, you know, there is good news that despite all of the things that we hear about, nightly updates about COVID, you know, it's one thing to talk about the number of cases, but it's also to look at what's trending out there. So worldwide numbers are trending downwards. United States overall trending downwards. In Wisconsin, trending downwards. When we look at Indian country, its trending is down. If we look at what's occurring native native cases here in the Bemidji area, Michigan, Wisconsin, Minnesota. It's good. It's everything is trending in a good way. And my only message, at least for this week, is not to get complacent or thinking that we're over this or that everything's going to be fine tomorrow or next week. We still need to maintain these safety measures that we all do. This is not going to be a sprint. It is going to be the long distance here, and that new normal for us is what's going to get us over the finish line, or at least until we have that vaccine in hand. So stay vigilant, stay true to your normals that you are doing right now. Keep doing everything, and so until next time,